The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello and welcome to the ASCO Guidelines podcast series brought to you by the ASCO Podcast Network, a collection of 9 programs covering a range of educational and scientific content and offering enriching insight into the world of cancer care. You can find all the shows, including this one, at podcast.asco.org. My name is BRITTANY HARVEY, and today I'm interviewing Dr. Natasha Leighl from Princess Margaret Cancer Centre in Toronto, Ontario, Dr. Andrew Robinson from Queen's University in Kingston, Ontario, and Dr. Gregory Riely from Memorial Sloan Kettering Cancer Center in New York, authors on therapy for stage 4 non-small cell lung cancer with driver alterations, American Society of Clinical Oncology, and Ontario Health Cancer Care Ontario Guideline Update. Thank you for joining me today, Dr. Leighl, Robinson, and Riely.
Thank you for having us.
Thanks for having us, Brittany.
First, I'd like to note that ASCO takes great care in the development of its guidelines and ensuring that the ASCO conflict of interest policy is followed for each guideline. The full conflict of interest information for this guideline panel is available online with the publication of the guideline in the Journal of Clinical Oncology. Dr. Leighl, do you have any relevant disclosures that are related to this guideline topic?
I don't have relevant disclosures, but I do have institutional research funding from a number of companies, including Amgen, Array, AstraZeneca, EMD Serono, Guardant Health, Eli Lilly, Merck, Pfizer, Roche, and Takeda, and personal fees from Bristol Myers and MSD, which are unrelated. Thanks.
Thank you. And Dr. Robinson, do you have any relevant disclosures that are related to this guideline?
I do not have any relevant disclosures related to this guideline. My institutional list of research funding is not as extensive as Dr. Leigh's, but is still fairly extensive and includes many of those companies.
And Dr. Riely, do you have any relevant disclosures?
I received institutional research funding from Novartis, Roche Genentech, GlaxoSmithKline, Pfizer, Mirati, Merck, and Takeda. But those are my only disclosures.
Thank you all. Then let's get into some of the content of this guideline update. So this guideline is an update of an earlier ASCO guideline on the systemic treatment of patients with stage 4 non-small cell lung cancer, which was then divided into 2 companion guidelines, one on systemic therapy treatment options for patients without driver alterations, which was published in 2020, and then this one for patients whose cancer has driver alterations. So, Dr. Robinson, can you give us a general overview of what this particular guideline covers?
Thank you, Brittany. It was a great experience to be part of this important guideline and an honor. As you mentioned, this guideline is on treatment of stage 4 non-small cell lung cancer patients with driver mutations, and it's a companion guideline to the earlier guideline published on treatment of stage 4 non-small cell lung cancer without driver mutations. The guideline followed a robust evidence gathering and evaluation process, as is standard for ASCO Ontario Health Guidelines. In this case, we ended up reviewing several phase 3 trials, as well as many earlier phase studies in specific driver mutation groups. If we look back to 2017, there were 4 driver mutation group recommendations included in the guideline, and we now have recommendations for 7 different oncogenes, as well as some recommendations that are specific not only for the oncogene involved, but also the specific mutation within that gene. The non-driver mutation guideline is referenced as well frequently in this guideline, as many of the treatment options that are recommended in that guideline are also appropriate for patients with driver mutations, with the exception of a couple of key mutation groups, such as EGFR. Recommendations in the guideline are qualified as weak, moderate, or strong, and the level of evidence for each recommendation is given. For many of these novel agents, the evidence is relatively low in comparison to what we are used to, with recommendations based on phase 2 trials without comparator arms and with surrogate endpoints for patient benefits such as response rates and duration of response, as opposed to quality of life and overall survival. Nonetheless, it was felt appropriate to include many of these agents in the recommendations, with the caveat that the level of evidence is weak or non-evidence-based. One of the recommendations in the introduction to these guidelines is to continue with studies, such as phase 3 clinical trials in many of these settings, in order to move from an informal consensus-based recommendation to a recommendation based on moderate to high-quality evidence. We hope oncologists and their patients will find these guidelines useful.
Great. Then, as you just mentioned, this guideline focuses on 7 targets: EGFR, ALK, ROS1, BRAF, RET, MET, and NTRK. I'd like to review those key recommendations for each of those targets. So first, Dr. Robinson, what is recommended for patients with stage 4 non-small cell lung cancer and an epidermal growth factor receptor mutation?
Thank you. In terms of stage 4 EGFR mutation positive lung cancer, the recommendations in the 2017 guidelines were to use tyrosine kinase inhibitors up front, such as gefitinib, afatinib, or erlotinib, and to follow that with osimertinib if a mutation was found, T790M, or chemotherapy, depending on what was available. In the current treatment guideline, we have recommendations not only for first and second line treatment, but also some acknowledgement and recommendations for treatment of patients with EGFR mutations other than the classical exon 19 deletion mutation or L858R. For patients with a classical EGFR mutation, several strategies have been shown to be superior to first generation tyrosine kinase inhibitors in the first-line setting, and the panel strongly recommended osimertinib to be used as first-line therapy with a high level of evidence based on the FLORA clinical trial. This demonstrated not only an overall survival benefit, but a quality of life benefit. Other strategies that have been shown to benefit include dacomitinib as first-line therapy, gefitinib plus chemotherapy as first-line therapy. Erlotinib bevacizumab and erlotinib ramucirumab are also options with a lower level of evidence, as they have not been shown yet to be associated with improved overall survival, but they are associated with improved progression-free survival. Most of the recommendations other than osimertinib are really recommendations for what to pursue if osimertinib is not available. If we move to patients with sensitizing but non-classical EGFR mutations, the evidence is certainly much more sparse, as are these patients, and the recommendation was for afatinib first line, or osimertinib was also considered an option based on phase 2 data. For patients with EGFR exon 20 insertion mutations, recommendation at this time was not to use a targeted agent first line, but to default to the non-driver mutation guidelines. For second-line therapy, after tyrosine kinase inhibition stops benefiting, the recommendation was to use doublet platinum chemotherapy with or without bevacizumab. The atezolizumab, bevacizumab, carboplatin, paclitaxel combination was acknowledged as an option based on an exploratory analysis of the phase 3 EMPOWER trial, but this was considered exploratory, and this regimen was not strongly recommended until further evidence accrues.
Okay, thank you. Then, Dr. Leighl, what is recommended for patients with stage 4 non-small cell lung cancer and ALK rearrangement?
So for patients with ALK rearranged stage 4 lung cancer, in the first-line setting, next-generation ALK inhibitors alectinib or brigatinib should be offered to patients. This is based on randomized trials comparing these to first-generation inhibitors, crizotinib specifically, demonstrating better outcomes, including progression-free survival and better intracranial activity. If you live in a region where alectinib and brigatinib are not available, earlier inhibitors like crizotinib or ceritinib should be offered, again based on high-quality evidence randomized trials demonstrating that these are better than chemotherapy. In the second-line setting, if your patient has received alectinib or brigatinib first line, lorlatinib may be offered. If your patient received an earlier generation inhibitor, crizotinib, they should be offered alectinib, brigatinib, or ceritinib, again based on randomized trials, and later lorlatinib third line may be offered. It's also important to remember that in this group of patients, chemotherapy, especially pemetrexed-based chemotherapy, is very active, and we would refer you to the ASCO Ontario Health non-driver mutation guidelines for chemotherapy recommendations when targeted therapy is no longer an option. I should also note that when we drafted these guidelines, we did not yet have results of the first-line lorlatinib study, the CROWN study, where we found that lorlatinib was also superior to crizotinib, the first-generation inhibitor. This is currently under review by the US FDA, so while it's not recommended in our guideline, we may see this added to future guidelines in our next guideline update.
Great, thank you. And then what is recommended for patients with ROS1 rearrangement?
So for patients with ROS1 rearranged stage 4 lung cancer, in the first-line setting, specific ROS1 inhibitors, crizotinib or entrectinib, may be offered. Because this is based on very impressive response rates and prolonged duration of response and patient benefit in single-arm studies, we have to recognize that alternatives may also include standard treatment based on the ASCO non-driver mutation guidelines, as well as other targeted agents such as ceritinib or lorlatinib that may be offered. If, though, your patient has progressive disease and previously received non-targeted therapy, targeted therapy with crizotinib, ceritinib, or entrectinib can certainly be offered. Also, if your patient has received ROS1 targeted therapy in the first-line setting, standard treatment based on the ASCO non-driver mutation guidelines should be offered, also with consideration of clinical trials.
And then additionally, what is recommended for patients with stage 4 non-small cell lung cancer and an NTRK fusion?
Thanks, Brittany. For patients with stage 4 disease and an activating NTRK fusion, entrectinib or larotrectinib may be offered in the first-line setting based on single-arm studies, including patients with lung cancer and very dramatic response rates and prolonged duration of response. However, standard treatment based on the non-driver mutation guideline, chemotherapy-based, may also be offered. In the second-line setting, if NTRK targeted therapy was given first-line, standard treatment with chemotherapy-based options may be offered second-line based on the non-driver mutation guideline. If NTRK targeted therapy, though, was not given in the first-line setting, entrectinib or larotrectinib may be offered to your patient. And I think at this point, we really don't know what the optimal sequence is for these patients, but I think it's very clear from the data that we do have that we want to try and identify this target and get patients on targeted therapy as soon as possible in the course of their disease.
Great. Then Dr. Riely, can you review what the guideline recommends for patients with stage 4 non-small cell lung cancer and a BRAF mutation?
Thank you, Brittany. I'll highlight that the BRAF mutation guideline pertains specifically to those patients with BRAF V600E mutations. The other BRAF mutations that we observe, we don't have sufficient data to make recommendations. But for those patients with BRAF V600E alterations, again, based on the quality of the data and the type of data available, the guidelines recommend consideration of first-line use of dabrafenib or trametinib. This is a consideration rather than a should recommendation, given the absence of randomized clinical trial evidence. But nonetheless, we recommend that they be considered in the first-line setting. If, in fact, you choose to use a non-targeted approach in the first-line setting, then the guidelines do recommend consideration of dabrafenib or trametinib in the second-line setting. So it's, again, in the first-line setting, dabrafenib-trametinib combination, or if not used in the first-line setting, then recommendation of dabrafenib-trametinib in the second-line setting.
Okay, then, what is recommended for patients with stage 4 non-small cell lung cancer and a MET mutation?
And again, specific for MET, we're talking about MET exon 14 alterations rather than MET amplification or other mutations which we might call emerging targets. So for patients with metastatic MET exon 14 altered non-small cell lung cancer, the recommendation is for the use of capmatinib or tepotinib. These are newer MET inhibitors that have recently been approved, and again, the guidelines recommend that they should be considered in the first-line setting. If, however, you choose to use non-targeted therapies in the first-line setting, then MET-directed therapies such as capmatinib or tepotinib should be considered in the second-line setting.
And then the final target addressed in this guideline, what is recommended for patients with stage 4 non-small cell lung cancer and RET rearrangement?
RET rearrangements are a relatively uncommon but important subset of patients with non-small cell lung cancer, and we have RET-targeted agents that are available. The current guidelines recommend that in the first-line setting we consider the use of selpercatinib, and in the second-line setting, if patients have not previously received a RET inhibitor, one should consider selpercatinib in that context. Patients have received a targeted therapy in the first line, then conventional chemotherapy with or without immunotherapy or bevacizumab should be considered. I will note that the guidelines were finalized prior to the approval of pralsetinib, and pralsetinib is another RET inhibitor with similar data in this context.
Great. Thank you all for reviewing those recommendations. So, Dr. Robinson alluded to this earlier, but Dr. Riely, could you describe what emerging targets the panel reviewed but were unable to make recommendations for at this time?
The development of treatments in patients with non-small cell lung cancer has really proceeded at a breakneck pace over the past 10 years. We've seen newer alterations identified, new drugs tested in those populations, and new drugs approved in relatively rapid succession. We have a number of targets that are currently being studied with new drugs, but we don't quite have enough data yet, or the drugs aren't yet approved, so they can't be included in the guidelines. Some of these targets include KRAS G12C. Recently seen a number of direct KRAS inhibitors that have been developed and seem to have activity in that group of patients, and that's a hot area to look forward to. We've also seen that patients with EGFR exon 20 insertions don't seem to benefit from currently available EGFR TKIs at the standard recommended dose, and so we don't have recommendations for their utilization here, but there are new drugs that are being developed to target this group of patients. Similarly, patients with HER2 mutations seem to not benefit from available therapies, but there are drugs that are being developed, and we look forward to seeing more data in that context. Finally, patients with NRG1 fusions are another emerging target, but we don't have good recommendations yet or good drugs yet.
Great, understood. So then, Dr. Robinson, in your view, why is this guideline important and how will it impact clinical practice?
So this guideline is important because it's taking a problem that we see in the real world, which is patients with lung cancer with an ever-expanding number of driver mutations, and trying to give recommendations for the integration of new therapies with standard clinical practice. It's important that it highlighted that for most of these mutations, without phase 3 evidence, the recommendations were to consider the targeted agent as first-line therapy, but also if it's not given first line, to use it in subsequent lines. And I think we need to recognize that these targeted agents, it's most important that patients get these drugs at some point in their care, even if we don't know exactly what the optimal point in their care is. The guideline was sort of the first one in lung cancer where we've taken a number of these rare mutations and examined the phase 2 data, and will likely be the template for what is going forward with an ever-expanding number of medications. So hopefully we get a bit of standardization out of it. Hopefully we've highlighted some of the areas that are still unclear and can be a template for the next round of targeted therapy guidelines.
Definitely, it's an ever-changing landscape. So finally, Dr. Leighl, what do these updated guideline recommendations mean for patients with stage 4 non-small cell lung cancer?
So this is really great news. And as Dr. Riely and Dr. Robinson have highlighted, in just a very short number of years, since 2017, we've made tremendous progress. We have at least 3 new targets, many new treatments for almost every class of targeted therapy indication in lung cancer. And most of these new targets are their oral therapies or pills, and many of them should now be offered to patients as first or second line treatment instead of chemotherapy. So for patients, this really means many more will be able to enjoy a chemotherapy-free world, or at least a chemotherapy-free period for a time. I think it's really important for patients and the oncology team to remember that genomic testing is essential, and it's an essential part of the stage 4 non-squamous non-small cell lung cancer diagnostic process. And in some places, any non-small cell lung cancer, this may be a very important part of the process. And it really doesn't depend on clinical factors like smoking. It's really about your pathologic diagnosis or in your tumor sample. So it's really key that we make sure that patients get their samples tested as soon as possible in their lung cancer journey, preferably with comprehensive profiling so we can identify any of these targets if our patients have them, and then get them onto the right treatment as fast as possible. If there isn't enough tissue for testing, liquid biopsy has emerged as a potential alternative. And I think it's so important for patients and oncology professionals to remember that PD-L1 expression, which is an important marker for immune therapy, it is not enough. At least a quarter of our patients with PD-L1 expression that suggests immunotherapy should be an option, in fact, have these actionable genomic targets, and we do know that in these patients, targeted therapy should come first. So again, tremendous progress, many exciting opportunities for our patients to be chemo-free for much longer, and again, important to get the right test as soon as possible so we can get you onto the right treatment as soon as possible.
Great. Well, thank you all for reviewing the extensive literature associated with this guideline and developing these recommendations, and for taking the time to speak with me today, Dr. Leighl, Dr. Riely, and Dr. Robinson.
Thank you.
You're welcome. And thanks a lot to the ASCO staff for doing all of the work in sort of herding the cats that are oncologists, as well as getting all of the references and the deep literature searches for us.
Agreed. Thank you so much.
And thank you to all of our listeners for tuning in to the ASCO Guidelines podcast series. To read the full guideline, go to www.asco.org/thoracic-cancer-guidelines. You can also find many of our guidelines and interactive resources in the free ASCO Guidelines app, available in iTunes or the Google Play Store. If you have enjoyed what you've heard today, please rate and review the podcast and be sure to subscribe so you never miss an episode.